The next speaker is G.F.Nieman, and he'll talk about PEEP and recruitment maneuvers as well, now with his model system.
Thank you. Well, this part of the presentation will be a continuation of from this morning's talk. And as you recall, we went through the pathogenesis of ventilator-induced lung injury and found that the alveolar flooding and surfactant deactivation caused alveolar collapse and instability, and that collapsed alveoli result in the loss of alveolar interdependence, and unstable alveoli can cause shear stress-induced injury. So effectively what we want to do is we want to recruit the lung and keep it open. We want to open up these alveoli and stent them open so that they are no longer unstable. And remember, so this is the diagram I had of the loss of alveolar interdependence, such that we have a heterogeneously ventilated lung and the alveoli can become unstable. This was just the in vivo validation of that concept. And so now that we, at least from these experimental results, have decided that unstable alveoli are the mechanism of one of the main mechanisms of ventilator-induced lung injury. What can we do to protect the lung? How do we prevent VILI with this knowledge? And I think somebody already mentioned Dr. Lachman's famous quote and paper, "Open the lung and keep it open," which he had a paper in Critical Care Medicine in 1992. And this is where the concept really was born. Let's, to eliminate all of these problems, let's just recruit the lung and keep it open with sufficient PEEP. And again, when we do this, we reestablish our alveolar interdependence, and it's very beneficial to the overall stability of the alveoli. So how do we open the lung and keep it open? Like we just said, we open the lung by a recruitment maneuver, and we keep it open with PEEP. So what's necessary to recruit the lung? Really two things. We need pressure. You have to apply a sufficiently large, high enough pressure to get these alveoli open, in time. And I think the time factor has maybe not been overlooked, but has been understudied. And the point is that we can, that when you apply a pressure, alveoli have different time constants, such that some will react and open immediately, and some will gradually recruit with the same pressure over a period of time. And I think Dr. Sittman mentioned several of the current recruitment maneuvers, but sort of the old standard is this 40-40, in which the patient is, they apply a pressure of, a peak pressure of 40 centimeters of water and hold it for 40 seconds. And so to give you an impact or a real feeling of what this temporal recruitment is, that once you apply pressure, that alveoli continue recruiting without additional pressure. What we did is we have an excised rat lung, and we injure the lung with a tween, our standard model. And what you'll see is the lung is just hanging from an endotracheal tube, and we're going to apply 40 centimeters of water pressure and hold it for 40 seconds. And what you'll see is the alveoli continually recruiting. You'll see them actually, this is just grossly, so you'll see the atelectasis popping open to inflated lung over the full 40 seconds. We're going to apply, okay, we've applied 40 centimeters of water PEEP, and we don't change it. So now we're just holding that exact same pressure. And as you can, all it's really showing is that as you hold that pressure over time, alveoli continue to recruit. So the different time constants of alveoli are very different. And so the importance of the, not just a recruiting pressure, but the time of that recruiting pressure is critical. And it's one of the arguments that also used for the use of high frequency oscillation is that it effectively goes up to a higher mean pressure and just holds, and that effectively you could be getting this kind of recruitment over hours. As we applied the pressure, you can see the atelectasis throughout the lung. You'll see approximately 70% of the atelectasis is eliminated immediately, and then the other 30%, or almost 30%, probably 25%, is recruited over time with the exact same pressure. So it's real important to remember that recruiting alveoli is not only to the pressure you add to them, but also the time that this pressure is applied. So what is the impact on alveolar mechanics of a recruitment maneuver and the addition of PEEP? And to answer this, our lab asked three main questions. Would newly recruited alveoli deflate following the recruitment maneuver? Would newly recruited alveoli be unstable following the recruitment maneuver? And how would PEEP affect deflation and stability of these newly recruited alveoli? And I just want to show you a CAT scan, which actually I've seen several today, of a lung being recruited. And this is what we wanted to look at from the microscopic point of view. So you can see a great deal of dependent atelectasis, and as you apply pressure, the atelectasis disappears. The lung is being recruited. So we want to do the same thing with our microscope and look at individual alveoli and see what happened to them. And so that's what I'm going to show you now is the individual alveoli recruiting during the recruitment maneuver. And what I want you to notice is that there'll be an instantaneous opening pressure where most of the alveoli in the field pop open. And this has sort of been, the term for this uniform alveolar opening has been avalanche recruitment. It was coined by Dr. Belasuki. And, but also watch, as we get into the end of the recruitment maneuver, you'll see another alveolar duct open up. So again, it's not only pressure, but pressure plus time. So this is the rat lung edge, and we've applied the pressure. You can see alveoli recruit, and a little later this alveolus recruits. So you can see the majority of the field recruits instantaneously as a unit. Now it's this alveolar duct right here, okay, over time, and we have an increased pressure, is going to gradually recruit and fill this void. And another alveolus just recruited over here. So the point being, it's not just the pressure, but pressure plus time. This is the numeric data from that study, and we looked at, we measured two things. We measured on the left y-axis the number of alveoli per field, and this is in yellow. We simply just counted the alveoli in the field to get an idea of how many alveoli recruited. And in the right y-axis, we have what is our stability index, our I to E delta. And all we do is take the alveolus, we do image analysis, computer image analysis of the alveolus at peak inspiration and then at end expiration. We calculate or measure the area of the same alveolus at these 2 points, and we just subtract the two. So the larger the difference in I to E, the more unstable the alveoli. The bigger the difference in size change from exhalation to inspiration. The higher the I to E, the more unstable the alveoli. So as you can see, before the recruitment maneuver, there was very few alveoli in our microscopic field, and these alveoli were very stable. During the recruitment maneuver, not surprisingly, we recruit a lot of alveoli. We put a lot of pressure into the lung. Obviously, we're going to open up some alveoli. And there wasn't any tidal volume, so these alveoli were very stable. The interesting part comes after the recruitment maneuver and with the addition of PEEP. Or not the addition of PEEP, but the going back to ventilation. And we were actually using a volume controlled ventilation. We had a tidal volume of 12 cc's per kilo and a PEEP of 5 before the recruitment maneuver. And then we went right back to that setting after the recruitment maneuver. And we found two things, both of them bad. This is with the 5 of PEEP. First off, a lot of these alveoli that we worked so hard to recruit almost instantly collapsed. So you can see a large, significant fall in the number of alveoli. And secondly, the alveoli that we did recruit are now unstable. And we've demonstrated previously that these unstable alveoli actually cause ventilator-induced lung injury. We repeated the study with another group of animals. This time after the recruitment maneuver, we went from 5 to 10 of PEEP. And here you can see two things happen, both of them good. A, we lost very few alveoli with the addition of PEEP. Few alveoli de-recruited, but not very many. And more importantly, the alveoli we did recruit are now stabilized. And these stable alveoli, we feel, won't contribute to a ventilator-induced lung injury. And from a clinical perspective, we saw another very interesting thing in this study, and that the increasing PO2s following recruitment maneuver do not always equal alveolar stability. So as you can see, this is before the recruitment maneuver, and this is after the recruitment maneuver with 5 of PEEP and after with 10 of PEEP. And if you remember, the animals with a 5 of PEEP had unstable alveoli, and the animals with 10 of PEEP had stable alveoli. But even in the unstable group, you see if you were just looking at saturation, we had a significant increase in saturation following the recruitment maneuver, even with these unstable alveoli. Actually, it wasn't statistically different, but it was actually a little higher than to 10. And a PO2 went from 101 to 170, also an improvement but even with this improved oxygenation, we still had unstable alveoli. So just because the PO2 is increased, that doesn't mean that alveoli are stabilized. Stable, you can see in the lower right, we have a PEEP of 0. Now what I'm going to do is just titrate PEEP so you can actually see the impact of PEEP on these unstable alveoli. So initially, alveoli, so we just added 5 of PEEP. You can see the stabilizing effect. But now watch that with still 5 of PEEP, after about 3 breaths, it loses its stabilizing effect. So that time constant of these alveoli were such that 5 of PEEP initially stented them open, but then they recollapsed. 10 of PEEP, now we have alveoli for the most part opening, but still very unstable. And again, this is a very injured lung. And you'll see as we progressively increase PEEP, we go up to 15 now. Now we're getting a much better stabilized lung. The alveoli now are looking more like those stable normal alveoli that don't change size greatly with tidal ventilation, at least in the 2 dimensions that we can see with this technique. And 20 becomes very stable. And actually 25, we can't see any difference, measure any difference between the 20 and the 25. So in this particular rat lung, by just stacking PEEP, it took as much as, it took really 20 centimeters of water PEEP to we really obtained alveolar stability. So we concluded that, our conclusion here is that without PEEP, these newly recruited alveoli would either be unstable or recollapse, and that without adequate PEEP, alveolar interdependence is lost. You have unstable alveoli and collapsed alveoli throughout the lung, and also that improved PO2 does not necessarily mean that alveoli have been stabilized. So now we've opened the lung up. Now how do we keep it open? And of course you add PEEP, and as Dr. Sipman had in his very excellent lecture, how much PEEP to add. And so this is always a really big dilemma. How do we know what's going on in the lung? And that's what's critical for the clinician to reduce ventilator-induced lung injury. So there are multiple ways of trying to decide which PEEP level that you would choose. Arterial blood gases would be one, improvement in blood gases. Probably the most studied has been the whole lung pressure volume curve. And that's where we would look at inflection points on both the inflation and the deflation portion of the curve, and get an idea of what's going on in the lung, both from a recruitment and a collapse point of view. And third are changes in lung compliance and tidal CO2. Obviously, tomography is also a very cutting-edge way of looking at lung mechanics and seeing what's going on in the lung, but unfortunately I haven't been able to secure a device yet, so I haven't done any of those studies myself. But I have done experiments on the other 3, and in this study we're going to look at the impact of blood gases and how they correlate with alveolar stability. And what this study was is we used saline lavaged rats. So we created our ARDS by saline lavage, and we lavaged these animals till their PF ratio fell below 100. So they were very sick animals. We then separated them in 2 groups. One group was with conventional ventilation and the other with high frequency oscillation. And in the conventional group, we increased PEEP until we increased the PF ratio from 100 to between 300 and 400. In the HFOV group, we increased the mean airway pressure until we increased PO2 from 100 to 300. So we weren't, the alveolar mechanics was the independent variable. We were choosing to lock onto PO2. So in both cases, we were just looking at blood gases like you could at the bedside and titrating our PEEP to give us what we considered relatively healthy blood gases. And as you can see, the average of these animals, the peak inspiratory pressure for the conventional was 34, the PEEP 9, and the ID 1 to 3. And for the HFOV, the mean airway pressure on average was 19.5, the delta P 15.7 at 6 hertz. And if none, oh, there we go, at least we got something firing up. So as you can see, remember this is at identical blood gases. You can see with high frequency oscillation, we see this little flutter of these alveoli. With conventional ventilation, we had very unstable alveoli. So the important thing is that PO2, we had stable alveoli in one group with the oscillator, but we didn't have stable alveoli with conventional ventilation. So again, each of these ventilator settings yielded the exact same improvement in PO2. However, with the oscillator, the alveoli were stable, and with the conventional, they were not. So again, just showing some of the the problems with just using PO2 as your indice of alveolar stability. And so we concluded from this study that improvement in arterial blood gases do not always correlate with increased alveolar stability, although they do sometimes. The use of the whole lung pressure volume curve and inflection points. As you recall, the theory behind this this technique, these are alveoli going from collapsed to overdistended, and this is the whole lung pressure volume curve. And it was believed that alveoli remain collapsed until we hit this lower inflection point, at which point there was massive alveolar recruitment. These recruited alveoli, lost my arrow. Okay, the recruited alveoli would then increase in size until we hit an upper inflection point, another change in compliance, and at this point the alveoli would be overdistended. And it was thought that by utilizing these inflection points, we could infer what was going on in the lung. Again, a redundant theme, that's what we really have to know in order to prevent ventilator-induced lung injury, and that this would be the logical way to, or at least a method to set your proper PEEPs after recruitment maneuver. And so what I want to show you now is, again, we went back to our laboratory, and I'm going to show you a recruitment maneuver, or not a recruitment, a whole lung pressure volume curve generated in a rat. So what you'll see is that the alveoli recruit and de-recruit in real time. So we're starting out with some ventilations. As you can see, it's a very injured lung, a very abnormal mechanics with alveoli collapsing and expanding. And this is a constant pressure, inflation pressure volume curve. So we're inflating this lung at a constant 2 centimeters of water increase in pressure per second. And you can see how the alveoli gradually increase or recruit throughout the entire pressure volume curve. No massive recruitment at a lower inflection point. However, now when we're deflating, you can see that there's more of a cutoff point on the deflation curve where we get a significant amount of de-recruitment. So what we did is we went to the lab and we analyzed both the pressure volume curve and the amount of aerated lung. So as you can see, this is a pressure volume curve generated with a super syringe in our rat model. You can see at 0 volume, there's very few alveoli open. We get some recruitment at 10. They're still de-recruited even at 20. And finally, in this model at 40, we had almost full recruitment. Notice that there's very little decrease in the amount of aerated alveoli from 40 to 20 on the deflation curve. And we found that just around 20 was the upper inflection point. And then following that, we did see a progressive de-recruitment of alveoli. And what we did is we actually used the Venegas equation and calculated these inflection points rather than just drew them. And then we did a correlation coefficient of the amount of aerated alveoli to the inflection points to see if which of these inflection points were actually giving us clues on how much aerated lung there was. And effectively what we showed, I'll just zero this right down. On the inflation limb, the lower inflection point, we showed very poor correlation. However, on the deflation limb, we showed a very high correlation. And that really, our in vivo stuff really confirms a lot of the excuse me, very good work that's been done with a CAT scan with Dr. Marini and Gattinoni's classical studies in both the clinical, on both patients and animals. They showed really a continual recruitment on the way up and de-recruitment on the way down, and really that the inflection point, the upper inflection point on the deflation portion of the pressure volume curve seems to be the better indicator of PEEP rather than the lower inflection point on the inflation curve. And so we concluded from these studies that proper interpretation of the pressure volume curves can be used to set PEEP and prevent alveolar collapse and stability and reestablish alveolar interdependence. However, these interpretations are somewhat difficult, but it does appear like the upper inflection point on the deflation curve is superior. And lastly, utilizing at least the stuff that we've done in our laboratory, utilizing changes in lung compliance and end-tidal CO2 to both recruit the lung and to set your PEEP. And we used for these studies, we used the servo-I and the open lung tool function on that ventilator. And I won't go into this in great detail. I'm sure there's plenty of people here that will be happy to show you all of the intricacies of this particular technique. But in essence, what we do is we have it a dynamic readout of both the dynamic compliance and the end-tidal CO2. So you can see that change in real time. And we utilized a protocol that's established by Mark Martinez from Sutter-Roseville Medical Center. And effectively, he has 8 points. Initially, we changed the pressure, change mode to pressure control, you optimize PEEP, optimize pressure control level to open the lung, your recruiting maneuver, decrease PEEP to deliver your optimal tidal volume, your low tidal volume ARDS net ventilation, decrease PEEP to find the closing pressure, again the decremental PEEP until you see changes in your compliance and your end-tidal CO2. And then you do another recruitment maneuver, adjust PEEP to 2 to 4 centimeters above the closing pressure, re-recruit the lung, and then you ventilate optimally with your low tidal volume and a fully recruited lung. And again, I don't want to go into too much detail here. There's plenty of people, and you can go to the workshop, I'm sure, and they'd be happy to show you this function. But in our study, we used pigs and did baseline measurements, and our major outcome in this wasn't protective lung ventilation, but really just on lung function. And so our lung function parameters were airway pressures, compliance, blood gases, and alveolar mechanics using our in vivo microscope. And we compared 3 groups of animals. We had acute lung injury with tween, with non-protective ventilation. Then we used our standard ARDS net protocol with a low tidal volume ventilation and a sliding scale of PEEP and FiO2 depending on the animal's blood gases. And we used the open lung tool function to open the lung fully and then set our PEEP above the closing pressure. And these are preliminary data. We haven't published these yet other than the abstract form. And just looking at static compliance, baseline, the compliance in these animals was quite good. Post-injury, it fell. ARDS net, we did not improve our the compliance with the ARDS net. With the open lung, we did have a significant improvement in the static compliance of these animals. Arterial PO2, baseline, post-injury, obviously these animals are extremely injured. Again, low tidal volume ventilation, and even with the PEEP, we did not significantly improve PO2, at least this animal model. We did take a gas during the peak recruitment with the open lung tool, and we saw a very large increase in PO2. And then following the setting of the PEEP, we saw a significant fall off of the PO2, but it was significantly higher than that of the ARDS net. This made us believe that possibly we had underestimated the PEEP necessary to keep that lung open, because the only thing we have, we don't have tomography or CAT scan. We're just going on gas or on compliance and end-tidal CO2. So we may have had a little bit of inaccuracy here in setting our PEEP level. And lastly, alveolar stability. We measured the classical IDE where we subtracted the volume of the alveoli at inspiration and at expiration. Post-injury, of course, we had very unstable alveoli. And we did find an equal stabilization with the ARDS net protocol and an open lung approach. So it appeared, at least on the surface of the lung, the only thing we can see with our microscope, that we did get identical stabilization with either of these 2 techniques. So we concluded, to conclude, we demonstrated that protective lung strategies can stabilize alveoli and reduce alveolar interdependence. That there's several techniques out there that are available that you can open the lung and keep it open, including things that we've tested and at least shown successful in the laboratory. Our use of the whole lung pressure volume curve, in particular when you set PEEPs on the expiratory limb of that curve, and also compliance and end-tidal CO2 changes. The optimal technique surely is not known. It's not how to recruit the lung. The best way to recruit the lung and the best way to maintain and to set your PEEP and maintain the recruitment surely has not been determined as of yet. And of course, to finally find out which ones of these are better, we have to go into open lung or to clinical trials and demonstrate that these open lung strategies actually do decrease morbidity and mortality in humans. And so our final goal is to by using protective mechanical ventilation, by adjusting the ventilator, we want to change the alveoli that are doing this with each breath to alveoli that are doing that with each breath, and hopefully reduce morbidity and mortality associated with ventilator-induced lung injury. And with that, I will conclude and answer some questions, and then hopefully reload these movies.
This talk is now open for comments, questions. Gary, let me start. Near the end there, you showed a slide of ARDSNet versus the others, and it looked like there was a difference in terms of some of the factors, and yet your alveolar stability was identical. So are you saying that it doesn't matter? I mean, I wasn't quite sure what the message there is.
I think the message was it was more or less a criticism of my own tool, if you will. Surely there was something going on differently in the whole lung, because we were measuring the whole lung functions, and yet the surface alveoli were equally stabilized. So I think if we were using Dr. Sittman's tomography, I think we would have seen a distinct difference in the two, because we would have seen what's going on in the entire lung. The limitation of looking at alveoli on the surface is a real limitation, and we understand that. However, it's the only method, at least to date, that we can actually see real-time alveolar change in size and shape. So what I think is saying is that just because we have stable alveoli on the surface doesn't mean that everything is good throughout the entire lung.
I know in some of the studies you've measured various indices of lung injury, because that's what really we're after.
Right.
All the other things are indirect. In any of these, did you actually measure some index of lung injury to show that one approach versus the other really actually decreases what you're concerned about?
No, actually we didn't. This was really just a pilot study, and that would be our next process, is to actually look at indices, look at cytokine production and other mediators of inflammation and damage. But we haven't actually compared ARDSNet to an open lung technique, although I don't have that protocol like right out in the lab right now, but we're looking at the high frequency oscillation, ARDSNet, also kinetic therapy and proning. And eventually we'll get to the open lungs and even combine strategies and techniques such as maybe open lung with the surfactant replacement. So ultimately I want to sort of test all of these various potential lung protective strategies and adjunctive therapies in a single animal model.
Rolf, can we have a microphone up here at the front, please? Microphone at the front.
This is sort of a follow-up to Art's question. Has anybody looked at the translocation of a marker protein in alveolar fluid as a result of a recruitment maneuver into the systemic circulation?
Well, surely there are multiple studies showing translocation, but help me out, I can't remember if they were directly due to a recruitment maneuver or just high tidal volumes. I mean, there's
high tidal volume, I appreciate all of that.
Right.
I was wondering whether you can cause a bacteremia, for instance, through a recruitment maneuver because you're inflating the lung to very high volumes, admittedly for a fairly short period of time. Has anybody actually looked at that and found either a positive or a negative result?
As far as I remember, Rolf, I think there are a couple studies not looking at bacteria with cytokines. It did not show, but I have to check that.
Maneuver and not
recruitment maneuver, not just
okay. And
with just the CPAP, I mean just a recruitment maneuver.
Yeah.
He has a study with bacteria. Yeah, I think that.
That was high tidal volume circulation, if I remember.
That's right.
I appreciate that the repeated, all this stuff, that barrier property things can make that happen. I was just wondering whether the epithelial barrier properties are affected sufficiently by stretching the lung to a high volume to allow that kind of translocation to occur.
You have data, Rolf, in terms of what happens in the membrane with single inflations, don't you? Membranes of cells?
Not as good as I would like. That is, in reduced systems, when you do it very rapidly, you injure. If you do it slowly, as most of the recruitment maneuvers really do, it's very difficult to injure a cell.
So you do have reasonable data. I mean, it's just hard, a little hard
cell,
to...
But the question was translocation.
I know.
I'm asking when you do have cell-cell contact issues, etc.
Yeah.
We have not asked or answered the question that I posed.
Yeah. Any other questions, comments?
Just one comment. I do remember some data that Marcelo showed me measuring the release of mediators in the bloodstream after recruitment maneuvers. So they had a boost and a elevation of mediators that was very, very brief in time, and after that they decreased very much. So
Was that published, Fernando? I don't remember seeing that. Do you remember?
I saw it in a presentation. I didn't, you know.
Okay.